All right, so let me see. Here you go. Yeah. So I have nothing to disclose. So around let me see. Okay, around intrarenal causes for acute kidney injury, about 5% is due to interstitial nephritis, while the most common cause is ATN, it's about 80%. So together, tubular interstitial injury is the major cause of intrarenal related AKI. I wanted to remember one thing. Interstitium of kidney is normally not seen, not visible. If it's seen, that indicated disease process. And the pathological interstitial changes, either focal or diffuse, are mainly three things. One, inflammation, which can be seen both in acute and chronic. Second thing is edema. Third thing is fibrosis. Through this lecture, I'm going to keep showing you the pattern, keep reminding you. I'm sure at the end of this lecture, you would absolutely remember and you won't forget for the rest of your life, I hope. All right, so this is the pattern of interstitial inflammation. Know that tubules are normal, preserved. There's many inflammatory infiltrate cells. In this case, is lymphocyte indicated by a yellow arrow with fewer eosinophil infiltrate. So remember, this is a interstitial inflammatory pattern. The blue arrow here indicating a space in the interstitial area, indicating interstitial edema. This is a phenomenon called thyroidization, including a 10 host 4 protein deposit in the tubules. Know that the epithelium is flat, indicating tubular atrophy, and there's has the interstitial space has collagen protein deposit with fewer inflammatory cell infiltrate. This is a pattern is a chronic interstitial nephritis pattern. Okay. Now let's talk about acute interstitial nephritis. AIN is a common cause of AKI. Most of us would know that. In fact, it may be more common since renal biopsy are not often done. There's a few studies has suggested that AIN may comprise about 15 to 27% of biopsies for acute kidney injury and about 1% of so-called healthy individuals who are biopsied for isolated proteinuria or hematuria, and about 1 to 15% of all biopsies in patients with renal disease. Drugs, still the most common cause of AIN. It comprises about 70% of cases. Renal biopsy remains the definitive diagnostic modality. Now, the hallmark AIN, like I mentioned earlier, I'm not going to repeat it here. Remember that fibrotic changes may be seen in AIN and can be as early as 7 to 10 days. And granuloma patterns can also occur in AIN and is more commonly seen in drugs related. I'll give you examples later. Okay. Now, the clinical presentation of AIN has been very heterogeneous. This table is summarized from a paper written by Prega and Gonzalez. Showed here, acute renal failure, leukocyturia, and non-nephrotic proteinuria are quite common. In addition to drug-induced AIN, infections, autoimmune disease, neoplasm, or acute allograft rejection can also cause AIN. And there's about 5 to 10% of AIN is idiopathic. Okay, so you have seen this before. Again, tubules are preserved. There's many lymphocyte infiltrate with eosinophil. This very commonly seen in drug-induced AIN. This is a pattern commonly seen in drug-induced. Okay, this slide here shows multinuclear giant cells with many eosinophil infiltrate. Anybody want to try what this pattern could be? This commonly seen again is drug-induced. Remember I said granuloma can be seen in AIN, and most commonly is drug-related. Okay, this is the pattern, all right? This one here is seen in medulla area with neutrophilic infiltrate. Specific pattern is in the peritubular capillary. This is a phenomenon called medullary necrotizing peritubular capillaritis. Is commonly seen in ANCA-induced interstitial nephritis. Again, tubule is preserved, many inflammatory infiltrate cells, and there's a interstitial edema. This pattern can be seen in acute allograft rejection. Okay. Now let's touch base a little bit drug-induced AIN. Again, like I mentioned, about 70% of the cases of AIN is due to drug-induced. In such cases, is called allergic interstitial nephritis. Now, among the antibiotics, beta-lactam, such as penicillin or cephalosporins, so far still the most common reported drug-induced AIN. In terms of quinolone, the most common quinolone associated with AIN is Cipro. Okay. In terms of sulfur-containing antibiotics, as well as the diuretics, again, you know that can cause AIN. Now, NSAID can cause interstitial nephritis alone, can also cause nephrotic range proteinuria, or both. Commonly associated usually is a minimum change in nephropathy. Okay, a little bit about H2 blocker. If anything reported associated with AIN, so far we have seen it's related to cimetidine. Otherwise, H2 blocker is very rarely linked to AIN. Okay. Now, what are the mechanisms that drugs cause AIN? There's 4 possibilities. One is drugs may serve as a heptin that binds the tubular base membrane, or drug can mimic antigen, which induce immune response to specific target that specific antigen. Drug can also bind to tubular base membrane, subsequently trap in the interstitial area, or drug can bind, form an immune complex in the circulation, subsequently deposit in the interstitial space. Okay, let's look at case 1. This is a 24-year-old male with a very significant medical history with aplastic anemia, status post umbilical cord stem cell transplant, which is complicated with the CMV, viremia, treated, also have EVV, related post-stem cell transplant lymphoproliferative disorders. He also have an ESRD on dialysis, which is due to TTP-HUS related to thrombotic microangiopathy. He got the transplant, and he, in a post-transplant, he initially urine output was pretty decent, 750 cc per hour, which subsequently reduced to 20 cc per hour, despite aggressive management with a tremendous volume, IV hydration plus diuretic, which is without any improvement. His creatinine initially was improved from 6.64 to 3.73, but subsequently increased to 5.5. Otherwise, he doesn't really have a major clinical symptom other than complaint of headache and left lower quadrant, which is where the surgery is. Okay. Past medical history, I don't want to repeat it. You can see here, medication-wise, significant for the immunosuppressant. In addition to that, he also on Valside, Bactrim, labetalol, and minoxidil for his hypertension. Non-contributory on his family history, social history is, he is, we think is pretty cool. He's a techno music producer, which because of him, I try to learn what's a techno. Otherwise, he doesn't smoke, he doesn't drink, and he doesn't use drugs. Okay. Physical exam significant for low-grade temperature. Blood pressure is okay. He's tachycardic. Urine output is not so great. A little bit volume overloaded with elevated JVP and extremity edema. Okay. Laboratory-wise is consistent with hyponatremia, metabolic acidosis, elevated creatinine, anemia, and the urine analysis show proteinuria, hematuria, and leukoturia. Okay. So he underwent a kidney biopsy, which showed possible acute interstitial nephritis, but also possible is acute rejection. So I want to talk a little bit about Bactrim AIN. It is well documented that Bactrim caused AKI due to AIN on native kidney. There's a few case studies also show that since Bactrim is commonly treated for PCP prophylaxis for transplant patients, and few case studies have shown that Bactrim can cause delay graft function or push early graft dysfunction. All right, let's talk a little bit of infection-induced AIN. Acute pyelonephritis can do that. Usually, the infiltrate usually is PMN. Systemic infection caused by bacteria, virus, or parasite can also cause AIN. All right. This slide here shows a lot of bacteria in the kidney with tremendous PMN infiltrate. This is a pathognomonic of acute pyelonephritis. Now, as we mentioned before, idiopathic AIN comprise about 5 to 10%. Even though I call uncommon, which is, but is about 5 to 10%. Patient commonly presented with a fever, but it's very uncommon to have eosinophilia or rash. Okay. This is the second case. 60-year-old lady was seen for evaluation of creatinine 1.91 milligram per deciliter. This was found on routine testing. Other labs show hemoglobin 11.4 with iron saturation 14%. She reported recently red eye and is seen by ophthalmology, diagnosed with anterior uveitis, and receives steroid eye drops. She has no rash, no arthralgia, no myalgia. She denies renal or urological problems. Past medical history is significant for breast cancer and with treatment. Social history, she's a non-smoker, still drinking alcohol. Okay. Medication is very simple, ions, steroid eye drop, and ACE inhibitor. Physical exams show elevated blood pressure, otherwise it's unremarkable, except also clear seen a red eye. Okay. Urea shows proteinuria and hematuria. And other tests is unremarkable. She got a normal renal ultrasound, negative aspect, normal ANA, and chest X-ray. So again, she also underwent renal biopsy, and it shows moderately to severe and active tubular interstitial nephritis. So together with her anterior uveitis, this patient have a Tenio syndrome. What is the Tenio? Tenio syndrome is an idiopathic TIN. It's thought may potentially is an entity of an autoimmune condition. It's commonly seen in adolescent girls. They usually present a constitutional symptom with worsened renal function. Children with Tenio usually have a very good prognosis. However, some adult with a Tenio may potentially require steroid treatment. All right, let's review a little bit about cause of AIN. Everybody knows that when we remove offending agent or you treat an underlying condition, AIN usually resolved. However, remember, likelihood of recovering is inversely proportional to degree of renal failure. And the scattering pattern of infiltrates normally associated with a better outcome. Also know that a patient with AIN, about 30% of individuals end up require dialysis. Okay, and then 50% of the patient with idiopathic AIN usually would end up with some degree of a renal dysfunction. Okay, how about treatment of AIN? Again, if there's an offending agent, you remove the offending agent, for example, NSAID or other drugs identified, remove it, the condition resolve it. How about steroid? Steroid is a mainstay treatment in idiopathic AIN or AIN associated with a systemic disease. Okay. Cyclophosphamide and cyclosporine has been used in it, but is normally used in steroid-resistant idiopathic AIN. MMF also been used, but it's usually in steroid-dependent recurrent AIN. Okay. Plasmapheresis or cytotoxic is controversial, not commonly used. If used, usually it's a patient with a condition with a strong anti-tubular basement membrane antibody. Okay, all right. A few words on corticosteroid. What do we know about corticosteroid? Currently, there's no prospective, randomized, controlled trials. I check it every year, and nothing come up. Still same information up to this point. Still 2 papers, one from 2004, one from 2008. Okay, both paper have opposite observation. All right. However, though, there's some publications suggest that if corticosteroid early institution of these drugs may potentially have a better prognosis and also have a more superior renal recovery. If you look at up to date mentioned, if you are considered to initiate a corticosteroid, you are encouraged to do kidney biopsy to confirm diagnosis of the AIN before you start a corticosteroid. Okay? All right, let's move on to talk about chronic interstitial nephritis, CIN. CIN has a much more diverse spectrum of etiology. I'll go over it later. However, though, its pathological pattern tend to be fairly homogeneous, meaning there's an interstitial fibrosis, there's a much less degree of interstitial infiltrate, okay, and you commonly see a tubular cell atrophy or dilatation. Okay, those are very common patterns. All right. Again, you all know this is just a remind. This is a typical pattern of CIN. Again, has uromodulin protein deposited in tubules, has a tubule atrophy indicating by the epithelial flattening, and the collagen protein deposit in the interstitial space with much less infiltrate cells. This is a typical CIN pattern. Okay. What is the clinical presentation of CIN? They often asymptomatic or they present it as symptoms of chronic renal insufficiency. Patient usually come in with incidental finding of worsened kidney function or abnormal urine analysis. Patient with the CIN can have anemia occur earlier, and about 50% of the patient would develop a hypertension or associated with hypertension, should I say. Okay. The etiology of CIN are many. Metabolic, such as hypercalcemia, hypokalemia, hyperoxaluria, hyperuricemia, cystinosis. All right, hereditary disease, ADPKD, medullary cystic disease can do that. Many drugs can cause a CIN, such as analgesic, lithium, cyclosporin, cisplatin, many Chinese herbal medicine, particularly aristolochic acid. Okay? Immune disease, hematological disease, or infection can also cause a CIN. Okay. So again, this is you saw this slide before. I hope by the time you see this slide, you know this is a granuloma pattern. It's a drug-induced interstitial disease, right? Multinuclear giant cells with eosinophil infiltrate. Okay. All right, this is case 3. 49 years old female presented with a 4-month history of nausea, fatigue, nocturia, and 11 pounds of weight loss. Past medical history is only significant for herpes about 2 years ago, and she self-medicated with a Chinese herb called London Xiaogang, which is 6 grams per day for 3 months. And she has been taking this medication intermittently in the past 18 months. Her last use of this Chinese herbal medicine was 5 months ago. She denies taking any NSAID. On physical exam, she's blood pressure is elevated, but no leg edema. Otherwise, everything is benign. Okay. Laboratories show low potassium, low bicarb, creatinine is elevated, low phosphorus, anemia. Urine analysis show Fanconi pattern, and ultrasound still show normal size of kidney. And the chemical analysis of her Chinese herbal medicine, it shows contaminated by aristolochic acid. And again, she underwent kidney biopsy, and this is the biopsy pattern. It shows tremendous tubular atrophy, very severe interstitial fibrosis, and there's literally, you don't see any interstitial infiltrate, or we call it hypocellularity. However, her glomerula looks relatively spare. Okay, so this is a pattern. It's a CIN pattern, but is a pathognomonic for aristolochic nephropathy. So aristolochic nephropathy is a condition. It can rapidly progress, leading to end-stage renal disease. The first outbreak is in Belgium with 100 young women who went to weight loss center and developed acute kidney failure. And initially it called Chinese herbal nephropathy, later on changed the name to aristolochic acid nephropathy. This condition has another name called Balkan nephropathy, because the local people at Balkan, they pick up a local plant to make bread, and in there also contain aristolochic acid. Okay, morphologically, this unique pattern of aristolochic nephropathy, if you listen to this lecture, that's all you need to know about this condition. Okay, is, like I mentioned earlier, extensive interstitial fibrosis, tremendous tubular atrophy. Now, the unique pattern of this condition is there's a gradient of intensity, ranging from most severe in the outer cortex to the less severe in the inner cortex and medulla. And another unique pattern is the glomerula is relatively spare. So if you see a pathology, you see this description, the first thing you need to think about is aristolochic acid. I have a case, a patient has 3 biopsies. Every single biopsy reported this, but nephrologists couldn't recognize the pattern. I end up analyzing this patient's supplement, and again, confirm it's aristolochic. And the supplement is not made from China, it's made in America. It's American, well-known, very prominent herbal supplement manufacturer. So just a reminder to you. Okay, what is the clinical presentation of AAN? They can develop condition as early as 2 months after the exposure to this medication. However, can be also as late as 3 years after this medication has been stopped. It's more common in female, and the presentation usually is, patient usually have no symptom until they have this explosive acute renal failure. Okay. The unique of this condition is patient presented proteinuria, usually mild, I'll elaborate a little bit more in the next slide. Patient develop anemia. The anemia tend to be more severe, proportional to the degree of renal failure. 80% of patients develop hypertension, despite they are young. Okay, like I say, patients tend to develop Fanconi syndrome. Okay, the creatinine doubling time is significantly shorter, and so it's a rapid progressive condition. And like I say, the course to develop the end-stage renal disease can be very fast when it, compared to other interstitial nephropathy condition. Okay, 54% of the patient have asymmetrical kidney. So when you see your patient, they have asymmetrical kidney sites. Think about this this entity as well. Okay. The proteinuria seen in aristologic acid nephropathy is not albuminuria. It's low molecular weight, not light chain, sorry. It's a low molecular weight protein, such as beta microglobulin, cystatin C, or Clara cell protein, etc. Okay. Another interesting thing is the low molecular weight proteinuria can be detected even before patient show the deterioration of renal function. So from the research per se, those low molecular weight protein may potentially can serve as a marker to study this disease. Okay. All right, let's move on to another condition. So this slide here shows you there's lots of here you go. A lot of cyst in the tubule and also in the interstitial area. So this is a condition, this pattern is a lithium toxicity. However, the most sensitive way to make a lithium toxicity, because we don't completely do a kidney biopsy when patient taking lithium chronically. So more sensitively, and one way you can do is this type of patient, you can make a diagnosis radiologically. This patient actually, when you do an MRI, you will see patient have a multiple microcyst, and those cysts usually the size is pretty uniform. Okay, so that's the pattern. Okay, how about analgesic nephropathy? This entity can cause CIN, can also cause a papillary necrosis or papillary calcification. It's commonly seen in middle-aged or elder patients. It's more common in female. Patient usually presented with nocturia, sterile pyuria, and associated with hypertension. Okay. Also, this condition also can associate with anemia or uroepithelial malignancies. Okay. We mentioned before, discontinue of this agent can slow or arrest the progression. Okay. All right, so this one is a pattern, again, is granuloma, as you see here, however, without a multinuclear giant cells. Again, by now you see there's this is an interstitial nephritis because there's a lot of infiltrate, and there's also interstitial fibrosis. And what can cause this condition? Sarcoidosis. Here, again, you would recognize here now is multinuclear giant cells, also have much less interstitial infiltrate with much severe interstitial fibrosis. So this one is still a sarcoidosis, but it's in a much advanced stage. So sarcoidosis related CIN usually is the pathway is through calcium. Patient usually you will see them would have a hypercalcemia, but more common you will see hypercalciuria. Okay, more common in men, and patients usually have a very atypical presentation. They don't have a typical sarcoid presentation. They usually respond well to steroids, as I mentioned earlier. Okay, let's talk about multiple myeloma-related CIN. I only wanted you to remember one thing. Multiple myeloma-related CIN is associated with CAS nephropathy. What is a CAS nephropathy? Here again, you see there's infiltrate cells in the interstitium. There's a interstitial fibrosis, collagen protein deposit, but the hallmark of CAS nephropathy is the cast deposit in the tubule. This cast, the color is pale in color when you stain it with PAS, and this is the hallmark of CAS nephropathy. When you see this pattern, think multiple myeloma. Unlike CAS nephropathy, this slide here shows there's a giant cast again. However, the color is much darker using PAS staining. In addition to that, you will see there's a interstitial edema. In addition to that, you also see a glomerula, a collapsing glomerula. Anybody want to try what this could be? HIV nephropathy. Okay, so that's the difference when you see a cast. A pale color is indicating light chain protein and associated with multiple myeloma. HIV, you should be also see a collapsing glomerula. Or if you don't see that in the field, the cast color is not pale because it's not a light chain protein. All right? Okay, I'm sure lots of you recognize this one. This is a nucleus inclusion body with virus in the center and surrounded by a darker ring, which is contain chromatin. So this pattern is a BK virus-related nephropathy. And this is another BK virus nephropathy. Again, it's a CIN pattern, right? In addition to inclusion body, you also have a fibrotic interstitium, very much less infiltrate cells. Okay. Now, this one here, again, you see a multi-nuclear giant cells. In addition to that, you see an area is necrotizing. So this condition pattern, we call it necrotizing granulomatous interstitial nephritis, commonly seen associated with TB. So this one here, you see a significant significant edema. They also show a significant interstitial fibrosis. In addition to that, you see this big ball here called lymphoid follicles with a thinning cortex. So this is a typical pattern of chronic pyelonephritis, which is associated with the CIN. And this is a obstructive uropathy. Again, I don't need to point out to you. You should be able to recognize that this is a CIN pattern. And so note that obstructive uropathy is associated with the CIN. Okay. How about the cause and treatment? The CIN, the progression is much slower compared to AIN. Again, the treatment is to treat underlying condition or remove the eliminate the offending agents. If it's a sarcoid, you consider use a steroid. Okay, biopsy are not often indicated because there's a lack of a specific therapy. Okay. I inserted this slide here, may not be a good place, but let me just mention a little bit GIN, granulomatosis, interstitial nephritis. This slide is a courtesy of Dr. Bijou, our pathologist. This is data from Brigham. The drugs still the most common causing this condition, GIN. Sarcoidosis is number 2, and idiopathic is about 10-11%. Okay. Let's just talk a little bit, few words on IgG4 related disease. You should know about this disease, okay? It is a systemic disease, involving multi-organs. If it's involving renal, its pattern usually is a tubular interstitial nephritis or membranous glomerular nephritis. Okay. Few large case studies shows IgG-induced interstitial nephritis, more commonly seen in elder men. And clinical presentation, about more than 50% of the patients presented at the time of presentation already have a renal insufficiency. And a unique character is those patients, not all of them, but big number of patients will present with so-called renal path. As a matter of fact, a quarter of patients with IgG4 interstitial nephritis, they require renal biopsy because the renal mass. They find a renal mass, and she got a biopsy. Okay. What is the histological or pathological pattern? IgG4 related interstitial nephritis usually have a plasma-rich infiltrate cells. The glomerular is relatively normal. This is another condition in addition to aristolochic acid. This is one. Glomerular is relatively normal. Okay, and in the serum, there's an increased IgG4 plasma cells. Histologically, has a variable degree of fibrosis. Because of such, there's derived 3 patterns of IgG4 interstitial nephritis. Okay, this is a pattern A. If you see now, interstitial have a very mild degree of fibrosis, has a very active many inflammatory infiltrate disease with a IgG4 positive plasma cells. So this is a pattern A. This is a Q pattern. This is a pattern C. Again, you probably recognize by now. This has a collagen deposit, interstitial fibrosis, tubular atrophy, and much less infiltrate cells. So this is a pattern C. So pattern B is sort of kind of in between. Okay. Pathologically, you find that a majority of patients with IgG4-related interstitial nephritis shows a IgG4 deposit in tubular basement membrane. Okay, and because of that, there's a thought this condition could be also autoimmune origin. How about clinical feature of this entity? Laboratory-wise, very high percentage of the patient has elevated serum total IgG and IgG4, okay, and also have a hypergammaglobulinemia. Patient, about 1/3 of patient, you will see eosinophil in the blood, and more than half the patient have a low complement level. Okay. Also, 30% of patients, you will find them have ANA positive. Okay. Another feature of this condition is, again, other than aristolochic acid nephropathy, this patient also have, in addition to have abnormal radiological abnormality of kidney, this patient also have a asymmetrical, potential have asymmetrical kidney size. Okay. All right, so what is the take-home message? Drugs are the common cause of AIN, and you should have a high clinical suspicion for drug-induced nephrotoxicity. Another point I wanted to mention is there's a nephrotoxicity of many herbal or conventional medicine, so-called supplemental, still unknown, because the FDA currently still is not regulating. So when you practice in your clinic, make sure you ask your patient about supplemental, because the patient never volunteer to tell you. You got to ask them. You in addition to that, you should also ask them to bring a bottle to show you, okay? I did not have a case here to show you. In fact, we have a case, patient developed acute renal failure because it's not part of interstitial disease due to stalk fruit. So that patients are taking it, but didn't even pay attention to look at the content, all right? Okay, so this is a question 1. 55 years old male presented with a renal insufficiency, kidney stone, hypercalcemia, hypercalciuria. Renal biopsy is done, and what is the diagnosis? This is the pattern. A, myeloma, B, TB, C, sarcoidosis, and D, obstructive uropathy. Who think it's A? B? C? D? Yep, the answer is C, right? We see over here, there's a granulomatous, but without multinucleus giant cells. Okay, question number 2. 65 years old male is a renal transplant recipient who presented with a renal insufficiency, sinusitis, hypocomplementemia, renal ultrasound show renal mass, renal biopsy show plasma cell, rich interstitial nephritis with IgG, C3 deposit in tubular basement membrane. What's the diagnosis? Anybody want to just tell me? A? B, that's it. That's it. So I think, this is, you should be, easy for you to remember this entity now.